altered mental state that is specifically of liver derivations, not necessarily sepsis or an alternate cause to your dysfunction. It does still require to be differentiated between an acute hepatic decompensation or acute and chronic liver failure, which are very separate entities. Once you've identified an individual that is considered to be in acute liver failure, the endpoints can be managed in different manners, but they're either going to recover or they're going to require transplantation, or you're going to have an poor outcome. And when it comes to who is eligible for these sort of modalities, specifically in terms of transplantation, it's important to identify who you're not going to consider. And that would be individuals such as with a hypoxic insult, where you can look to get fairly quick recovery, infiltrative liver diseases such as lymphoma or other forms of malignant infiltration, patients who have chronic liver disease who are presenting with a phenotype of acute liver failure do also qualify. And here we're talking about individuals such as with a fulminant Wilson's presentation, a fulminant autoimmune hepatitis, or a VAD-PRE. Liver resection for secondary deposits or a primary liver lesion, and patients with acute alcoholic hepatitis are unfortunately still not considered candidates for transplantation. I think the acute alcoholic hepatitis, the guys at VG recently know it's a bit of a bugbear, and I'm working on it. Right, in terms of etiology, it is different depending on where you're from. Italy, I think you're from the Maldives, you might be seeing a little bit more hepatitis E. It is quite common in the subcontinent. If you look at Bangladesh, for instance, 75% of individuals diagnosed with acute liver failure are secondary to viral hepatitis E. We don't really see it that much because we have a different genotype in Southern Africa that has a different presentation. So hepatitis E in our context is generally considered to be more of a chronic hepatitis. Where's our folks from the Sudan? Yeah, there we go. Right, I thought there'd be a few more. So you guys representing there, you can see hepatitis B, hepatitis E, hepatitis A are all of considerable numbers there. I think our South African, I've got some South African data to show you guys in a second. There is a classification for acute liver failure. You're generally talking within a week. Hyperacute, acute will be anything up to 4 weeks, and then subacute beyond that to 12, and even some people say up to 24 weeks would still be considered a subacute failure. And why is this important? Your rapid fulminant patients, rapid down, and often if you can get them over that bottom lip, they can recover and may not need liver transplantation. This is opposed to your individuals with a more subacute, grumbly presentation, like a lot of the drug-induced liver injuries that we see secondary to efavirenz and so on, where they may actually look okay, they're kind of meeting criteria, but unlike your paracetamol only that's intubated in ICU, these patients can sometimes even be managed in the ward until a septic insult hits, and then there's trouble. So the reason that it's important is in terms of those grumblier ones often still require the transplant, whereas rapid up, rapid down may not necessarily. Etiology as a prognosticator, then, just in terms of what I was talking about, just have a look in terms of transplant-free survival. As low as 14% for autoimmune, fulminant autoimmune disease, 19% for viral hepatitis B, 22% where they're not really often certain what the cause is, and then drug-induced, about a quarter can make it without a transplant. Look at that compared to paracetamol that I just mentioned, where almost 2/3 of the patients can spontaneously recover. Let's just quickly go through principles of management. We're talking specific and non-specific. If this patient is already showing signs of disease. At our center, we do initiate early, continuous renal replacement therapy, as we do feel that it is neuroprotective. Neurological support in terms of the basics, keep them head up 30 degrees, keep the room quiet, don't have all the alarms going, don't have all the lights flashing. That extra neurological stimulation can actually cause blips in intracranial pressure. N-acetylcysteine, even for non-paracetamol associated liver disease, there is a meta-analysis out there showing that these patients did better when you gave the N-acetylcysteine. If you're referring them to us at DG Keysholder lactulose, lactulose, if you're being considered for transplantation, results in distended bowel and can result in bowel injury. These patients are immune suppressed, and if you have bowel injury associated with transplant, your outcomes are poorer. Busy slides, apologies. Let's just go through a few of these quickly. Paracetamol, start your N-acetylcysteine early, even if you think it's a late presentation, just please give the Parvolex. There's very little that you're going to lose in not giving it. Acute Brachyury syndrome, it's a very classic presentation, acute right upper quadrant pain with ascites, and on POCUS, you see the Dopplers showing absent vessels. Mushroom poisoning, this often occurs in familial clusters. We had one of these a couple of years ago that Tim and your guys wrote up that family cluster where they went out gathering, picked up Amanita phalloides, and autoimmune disease. Please be careful with too much steroid, especially in these fulminant patients. Too much steroid can have adverse effects, including precipitating sepsis. That's not to say don't give them a trial. You just need to be careful. Acute ischemic injury, restore the cardiac status and restore your hemodynamics. Search for an etiology, it is important. Look for the paracetamol, young patient, boyfriend, girlfriend, troubles, et al. It happens. Have there been any recent change in prescriptions? Is there anything about gastrointestinal effects? Has there been a travel history? Have they been to Durban lately? You know, hepatitis A. We've had 2 patients that went out to Durban, picked up hepatitis A, subacute, and hepatitis. All right. Any other conditions that could almost result in a worse presentation? Right, so is the patient pregnant? Remember, certain viruses in the context of pregnancy, not necessarily a great thing. What degree of pregnancy are they? Are they late stage? Could this be acute fatty liver pregnancy? Any further immune suppressive chemotherapy, right? Rituximab and hepatitis B they don't make each other, right? Any other history of autoimmune disease, and then decide, is liver transplant feasible in this patient? I think crucially important is your psychosocial history. What is happening? Is this a third parasuicide event? Has the patient got access to other forms of care? Once you've made your diagnosis, you're looking at your basic investigations, try and do things relatively specifically. In terms of testing for Wilson's disease, which regularly happens, please don't do your 24-hour urine copper and your ceruloplasmin as your standard non-acute liver failure tests. They are very poorly specific in the context of acute liver failure. You're going to have increased copper excretion because your liver is breaking down. There are other ways to diagnose this, including bilirubin and ALP ratios that you can look at, the fact whether you've got a Kuhn's negative hemolytic anemia should give you those sort of inclinations. Stress ulcer prophylaxis, antibiotics. We cover our patients with antibiotics from the get-go. You've got Kupffer cell dysfunction, and sepsis often kills these patients as well. So that should be your initial investigation panel. Anti-HSV, we generally don't do serologies and we do PCRs. The HSV, we had one not too long ago, and unfortunately this has a very poor prognosis, and it is fulminant. You can have someone go from relatively okay to passing away within 48 hours. It's really, it can be very quick. In terms of your markers, look at potassium, look at phosphate. Are they dropping? That could be a sign of recovery. Are they staying static? Not a sign of recovery. Look at your urea. A low urea suggests that your liver's not producing. And then look at your lactate, obviously. So, you know, just looking at your various aspects here in terms of your organ-specific complications, you've got your coagulation. I wouldn't chase an INR in these patients. Your neurological complications in terms of raised intracranial pressure. We are doing less subdural pressure measurements these days with these patients and doing more transcranial Doppler measurements where indicated, and remember mannitol if you're getting spikes. Cover them for infection, make sure that your blood pressure stays on target with a MAP of greater than 65. Once you've got these patients on CDBHD, you want to try and, once they're on CDBHD, it is a bit difficult to talk about those electrolyte parameters that I was talking about. You're going to have them intubated once they're grade 3 encephalopathy. You're going to use relatively quick-acting agents. Propofol, for instance, will also cover you for seizures. We often put them on EEG monitoring and assess them in terms of seizure activity, covering with drugs with a low risk of hepatotoxicity. In terms of why this is so, watch your ammonia level. In an acute patient, a level of over 200 is associated with raised intracranial pressure, and that's where your CDBHD can come in terms of keeping that suppressed for longer. Any individual with renal impairment, as these patients often do have, and as part of your listing criteria, should be put on. Vasopressor support in terms of maintaining your renal arterial pressure is also considered. Sepsis, in terms of your Kupffer cell dysfunction and bacterial translocation, also worry about urinary and respiratory sources. These patients are often difficult to intubate because they're not entirely cooperative, especially at a grade 3. Broad spectrum antibiotics and antifungal is what we generally go with, and we regularly culture these patients. In terms of when to use, there are multiple criteria that can be used, including just the simple modified stage liver disease. A score of greater than 30 should be considered for a MELD score in order for you to list. I think the most information and most research out there is associated with the King's College criteria: acute liver failure due to paracetamol and then non-paracetamol indications. Paracetamol, lactate is generally a problem and they're often acidotic. On admission, you try and resuscitate them and then see where are we sitting. If they're still sitting with a lactate of more than 3 or a pH of less than 7.3, you need to list that patient. Otherwise, hepatic encephalopathy more than a grade 3, serum creatinine more than 300, or an INR more than 6.5 can be considered. If this is not paracetamol related, encephalopathy with an INR more than 6.5 is an indication for this. Otherwise, 3 of the 5 following criteria: etiology, age, the interval between jaundice and encephalopathy being greater than 7 days, bilirubin more than 300, or an INR more than 3.5. Let's just try and remember it as the A, B, C, D, E. A, age; B, bilirubin more than 300; C is your coagulation; D is your duration; E is etiology, spelled the American way. Right, in terms of our local data, this was a study that, I can't remember where, I actually presented in some meeting, I can't remember where. But 25 patients, of those 13 were DILI. Obviously this was in the efavirenz era where we had quite a number of those sort of patients, but otherwise significant number of viral, autoimmune, and Wilson's disease were also coming through. Of those, only 4 were patients that we weren't able to get an etiology into a figure out, of course. 14 of those 15 were then transplanted. Overall survival rate in terms of intention to treat, 11 out of 25. But then post-transplant patients, then somewhat better, with about 2/3 of them surviving. Most of the mortality occurring in the first week after transplantation. And what you can see there is just that line there going across in terms of once they're transplanted, they do pretty well. So yeah, that is it for me. I'm sorry, okay, 2-3 minutes over. I tried speaking quickly. I'm going to be handing over now to Prof. Roka.